Yeah, we paid.
Oh, there's Mary. Why is
It was because she was a mom.
so? Hello, everyone. This is Heidi Christensen, and I'm speaking to you today from the Center for Faith and Opportunity Initiative, or the Partnership Center as we're known, here at the U.S. Department of Health and Human Services. And I am joined by our co-hosts, friends from the National Hospice and Palliative Care Organization, as well as my colleague Mary Lazar, who you just heard from the Administration for Community Living, or ACL. This is for the first part in a two-part webinar series on caring for the seriously ill, balancing care with hope, about palliative care and hospice. Now, I'll say more about today's part one in a moment, and then I'll introduce our speakers. But first, a word about the center and then a few housekeeping notes. As many of you know, the Partnership Center works to support faith and community-based leaders and service providers by sharing timely information and models of community-based practice and resources and educational offerings with the hope that it will help strengthen the community's response to public health and human service initiatives. Now, the issue of caring for the seriously ill or the end of life touches down squarely at the intersection of our health and our humanity. And most of us have or will have the experience of supporting a seriously ill family or community member in our life. Palliative care services and hospice can dramatically improve the care journey for patients and families. And so we felt it was important to offer a learning opportunity that would both educate and offer practical guidance for those involved in this journey. Our webinar presentation today, Part 1, Demystifying Services for the Seriously Ill, Palliative Care and Hospice 101, will provide an overview of these healthcare services and discuss the essential differences between palliative and hospice care. It will also focus on how communities can connect their members to these person-centered services that address their physical, emotional, and spiritual needs with respect and with dignity. And we'll learn more from very helpful real-world examples. But first, a few housekeeping notes. As always, this is an educational webinar. It is off the record and not intended for press purposes. But if you are a member of the press, please let us know. We will be happy to connect you to the press office here at HHS after the program. The program runs an hour. It is a very full program, but we welcome your questions and comments throughout the webinar. You will see the Q&A box, and we will be monitoring that throughout the program. We have folks standing ready to answer your questions. And as a final note, we will be sending a link to the recording of today's webinar in the follow-up email to everyone who has registered, along with links to some of the resources referenced throughout the program. And a certificate of attendance will be sent to those who participated today. And now I am delighted to invite our colleague, Mary Lazar, Principal Deputy Administrator for the Administration for Community Living here at HHS, to welcome you and share a few resources. Mary?
Heidi, thank you so much, and this is just a wonderful opportunity for me to talk about a topic that is, I consider palliative care and hospice to be a gift. And it's a gift we don't often talk about. We don't talk about enough. We don't talk because we're afraid to get into the topic, because we know it's something that deals with certainly some, for many, end-of-life issues. But I had the distinct pleasure of being part of the Conversation Project when it was first initiated several years back, and I learned what a great opportunity it is for people to learn about and experience these gifts of palliative care and hospice care. Our Administration for Community Living has a very laser focus on older adults and people with disabilities, and these individuals often face pain management, chronic pain, and issues such as that. And these are where the gifts of palliative care provide that pain relief, but it's more than that person-centered pain relief. Palliative and hospice care reach families. So they focus on the individual and what does the individual need for quality of life, but they reach into families because we all know that when someone is in pain, we're all in a sense in pain, and redirecting our efforts in our lives around how do I find comfort for that individual. When we talk about hospice, we talk way more about just management of pain. We're talking about spiritual support and respite for the family and friendly visiting from someone outside the family. Sometimes that's the person someone can open up to because the family can't talk about it. There are so many gifts and resources brought to people through palliative care and hospice. I hope that, and I know that if your hearts are open, you'll learn a lot, but if your hearts are open, you'll demystify some of the concerns people have of talking about palliative care and hospice care with individuals and bring that gift to them. So open your hearts and learn today and at the next opportunity, the second session. Certainly ACL, through our resources and our focus on the populations that I just mentioned, support certainly what the Partnership Center is bringing to all of you. I encourage you to take these gifts and reach out to the community and individuals who would benefit from them. So again, Heidi, it's my pleasure to be part of this, and I appreciate the support that we can bring to one another in this effort.
Mary, thank you. Thank you for that insightful thoughts and comments. Thank you for your leadership at ACL. You all have been great partners to us and to the communities that we serve. Thank you so very much.
Thank you.
So now I'd like to introduce the presentation and introduce the team who will provide our presentation for today from the National Palliative and Hospice Care Organization. Lori Bishop will be our primary presenter today. She is a healthcare nurse executive focused on innovative and transformational interdisciplinary care delivery models for the seriously ill population. She lends her extensive clinical background in hospice and palliative care to her current position as Vice President of Palliative and Advanced Care at the NHPCO, as their acronym reads. Previously, Lori was the Chief Advanced Illness Management Executive for Sutter Health, and she served there an average daily community of 2,500 seriously ill patients across Northern California. And before that, in her prior executive role at Unity Point Health, Lori facilitated the creation of a system-wide integrative palliative care program, which received the prestigious Circle of Life Award. And Lori will be assisted throughout the webinar and the Q&A by her colleague, John Radulovic. Excuse me, John. John has worked on behalf of hospice and palliative care at the National Association level for 24 years. He joined the National Hospice and Palliative Care Org in 2003, and he focuses on both internal and external communications of the organizations. But John not only serves as one of the spokespeople for the organization, but he assists in the national and regional media projects involving end-of-life care and creates all their materials for their members to use in their outreach and communication efforts. So we are in good and expert hands today, and I understand Carla Cheatham, who will be our presenter next week, is also on the line to help with Q&A. So at this point, I will turn our presentation over to Lori. Lori, are you ready?
I'm ready.
Okay, over to you.
Thank you. Thanks for the kind introduction, and I appreciated Mary's words as well. Let me just get to my slideshow for you all here. And as you mentioned, we welcome questions and comments throughout the presentation. I know John's at the ready to interject as needed to stop the presentation and answer your questions. Here's what we're going to cover today. We're going to look at the differences between hospice and palliative care. There's a lot of misunderstandings out there. A lot of people see them as the same thing, but they are very different. There is a bit of challenge, and we'll look at that with palliative care because it doesn't have a truly defined benefit as yet within Medicare. And then we will go into a little more detail about the Medicare hospice benefit so you can appreciate the richness of the benefit as it is delivered today. And then we can also look at some examples of the ways hospice and palliative care programs have partnered with local faith-based organizations. And that kind of is a great segue for the part 2 of this series that Carla will provide in the weeks to come. Okay, here we go. The first thing we're going to talk about is palliative care. I think of palliative care as much broader than hospice. Hospice, some people would say, is a subset of palliative care. But when we think about palliative care, or you may hear it in your community as supportive care or advanced illness care or advanced care, there's a lot of names for that care, but it really is focused on the care of the seriously ill, regardless of what stage they are in that illness. So it can be introduced at the time of diagnosis. If you get a new diagnosis of a serious illness, that's a great time to think about, what does this mean to me and my loved ones? What matters most to me upon hearing this? What care path do I want to go down? And how will that impact my quality of life? And then you can get back to palliative care anytime you're really at a fork in the road with that serious illness and revisit some of those things. So when you think about the services that palliative care provides, the hallmark of that is what we call advanced care planning and goals of care discussions. And when I think of what that means, I think of making treatment decisions that align with what my quality of life is. And no one can know that but me. So that starts with a good conversation with a palliative care provider or my primary care provider to say, look, this is the stuff that matters to me, and how will this treatment impact that? It may be that I want to make sure that I have full function, and will this treatment impact my ability to function? And if so, how? So it's just kind of engaging in those conversations. As Mary had mentioned, there's also a lot to do with symptom management. You can imagine when you have a serious illness that there are impacts from symptoms that you experience with that illness. It may be pain, it may be difficulty breathing, it may be changes in your energy level, or it may create some level of depression for you or anxiety. It may be a financial burden that you're concerned about. So this is where we get into the holistic nature of care. And we do that through a comprehensive assessment. And then we do focus on symptom and medication management and care coordination to make sure that that seriously ill individual and their family or caregiver get connected to the right resources at the right time to help them be as healthy, as well, with the highest quality of life possible for as long as possible. This also means providing education and support not only to that individual, but their caregiver. Now, the challenge here is payment. Right now, the only components in our traditional fee-for-service reimbursement mechanism of Medicare, the only component that's reimbursed are the physician or the non-physician practitioner, which is the nurse practitioner, clinical nurse specialist, physician assistant, and they are reimbursed, but the other members of what we would call the interdisciplinary team, the nurses, the social worker, spiritual counselors, aid services, those are not currently reimbursed under traditional Medicare at this time. There are some managed care plans, both commercial, Medicare Advantage, and Medicaid, that are looking at the coverage of the interdisciplinary team, and they reimburse typically at a per beneficiary per month. So there is hope that we will continue to grow the access to palliative care services. Right now, they are somewhat limited. They are primarily available in hospital settings. That's really where they kind of were birthed, if you will. And now they are starting to expand more into the community space both in clinics and, more importantly, in patients' homes. But you can see with that reimbursement structure that we have today, it is a little bit challenging. So hopefully help is on the horizon to improve that. Then there's this issue of accountability, and that is the quality of care. And how do we ensure high quality palliative care given that we don't have the reimbursement mechanisms and the regulatory mechanisms to monitor palliative care services? So basically, the quality reporting today is what the physician or non-physician practitioners report, which is called the Merit-Based Incentive Payment System, or MIPS, and that is where they provide some quality reporting. Now, some of the contracts with plans from Medicare Advantage or Medicaid or commercial plans, they are starting to require quality reporting as well. So we are just, you can see that just from the little picture that we have on this slide, that palliative care is still kind of in its infancy, or maybe it's a toddler. Hopefully we're going to get it to the teenage phase here soon. So when we look at these two services, oftentimes people think they're the same thing, but I hope you see that palliative care is a little further upstream. Hospice is closer toward the end of life, and that's why so often we misunderstand this benefit and think we can only access it when we are dying. It's almost a bit of magical thinking that if we don't talk about hospice or access the hospice benefit, then we aren't dying. But if we acknowledge hospice and we use the benefit, we're going to die tomorrow. So it's just a misunderstanding. This benefit is available for the terminal phase of an illness only, and that is if a patient has 6 months or less to live. But again, that's if the disease runs its natural course. There are some people that are on hospice much longer than that. Unfortunately, there are a lot of people that only use hospice for a very short period of time, which could be a week, it could be less than a month. So we'd like to change that because it is a very rich, comprehensive benefit under Medicare and Medicaid and most commercial insurance, and you are entitled to that benefit. It does provide for the interdisciplinary team. It's person and family centered, just like palliative care is. The majority of that care is focused in the home. 98% of hospice care is provided in that individual's own home. It is more focused on comfort care, and that's another barrier, I would say, to hospice care, the perception that I have to give up disease-modifying treatment in order to receive hospice care. Oftentimes, however, at that point in a disease, some of those treatments are more detrimental than beneficial. So again, it goes back to those conversations. Now in palliative care, that can be done right alongside disease-modifying treatments. And again, it's all about those rich conversations about the benefit of that treatment versus the burden, and does that align with my goals of care? We're going to go a little bit deeper into hospice now. John, is there any questions we need to answer before I get deep into hospice?
Hi, Lori. One person just asked for clarification that an MSW who does counseling, can they, in a palliative care patient, can they be reimbursed under Medicare Part B?
Thank you, John. That's a great question. A licensed independent clinical social worker can bill for any services related to a behavioral health or mental health diagnosis, which is a DSM-5 code. And so they can do individual counseling and family counseling, but only a licensed independent clinical social worker can do that. An MSW cannot.
Okay, and Lori, one last question. Could you share just a typical or standard PM reimbursement by a commercial plan might look like? Or are they so varied, it would be hard to answer that?
They are varied, and I don't know that I don't know that it's appropriate to even share dollar amounts in a forum forum like this, but they do vary. I can give you an example that's out there right now in a new care model that CMMI has just introduced that is more of a transition of care model that is I would say a subset of palliative care, and that model is going to reimburse at $275 per beneficiary per month, but $50 of that is going to be held back and will get paid out annually based on some quality measures. So that's just one example that's out there. There is a variety, and I think it's really important that a provider of that service understand what their costs are so they can negotiate an adequate reimbursement rate with the plan. So there's a lot of opportunity there.
Oh, yeah, Lori, thank you. If you don't mind, let's get back to what is hospice?
Thank you, John. So I've already alluded to the fact that hospice is a Medicare and Medicaid benefit. It's a rich benefit that we've had for 40 years. You have to be eligible for Medicare Part A to access the benefit, and you must choose to enroll in the benefit. So you sign a consent form that says that you will give up Medicare B billing for anything related to your serious illness, and that will be covered by the hospice benefit. So it's a comprehensive benefit that covers everything you need when you are at that point in your disease process. So the patient and the family are seen as a unit of care, and that comprehensive interdisciplinary team really does focus on the whole person: physical, emotional, social, spiritual. There's also this beautiful requirement baked into the benefit that hospices must provide trained volunteers. And so we'll talk about that in a little more detail on another slide. But I think it's just really important that you understand this is a great benefit, and it is focused on the care during the terminal illness. And again, that's less than 6 months to live if the disease runs its natural course. That diagnosis or prognosis needs to be certified by the hospice physician and the attending physician. So the primary physician for that individual remains their attending physician during hospice, unless for some reason they don't have a primary physician, and then they can opt for the medical director of the hospice to become their attending or primary physician. The focus is on comfort, not on cure, and the reason for that is that illness is in a phase that is no longer able to be cured. Actually, many of the serious illnesses that we take care of patients with in hospice care are not curable diseases when they're diagnosed, but we are just looking at them toward the end of that disease, when really it's the symptom burden that needs aggressive management rather than aggressive disease modifying treatment. We see some people that choose aggressive disease modifying treatment up until the time of their death, but they may actually, in some cases, shorten their life expectancy choosing that path, and they may have a diminished quality of life. There's actually some studies out there to show that that hospice path with aggressive symptom management and a focus on living well and living with the highest quality of life that matters to you, you actually do live longer and you enjoy that time much better. And it's spent typically more in your home, surrounded by the people you love, rather than going to doctor's appointments and getting to the emergency room and being hospitalized or in intensive care. So let's look a little deeper still. We talk about the care being provided by a trained team of professionals. There is a certification for palliative care and hospice for all the members of the interdisciplinary team. And there is also rigorous training for volunteers. So that is part of the requirement in the conditions of participation for the hospice benefit. These volunteers go through a training, and then they get regular in-services to maintain that skill set and support, just like the employees do, to manage, to support the team in the care of that individual. So they can come in and provide respite for the caregiver. They can, veteran to veteran is one of the volunteer programs we see a lot. It's a great resource. And it's kind of from the grassroots of hospice, where it got its beginnings before it was a Medicare benefit. A lot of the interdisciplinary team was volunteer before there was a benefit. So it's keeping the essence of that grassroots palliative or hospice service. Now, when we talk about the comprehensive coverage, that includes reimbursement for physical care, counseling, medications, equipment, and supplies to relieve suffering and promote quality of life. So the individual does not have the burden of paying for that. It is all paid for under that benefit. And that's another reason why people should access this benefit when it's time for them to do so, when they meet the criteria, because it can help them relieve some burdens on their medications and treatments that are appropriate for their quality of life. Equipment they may need, so a hospital bed or oxygen, those are all covered when they are related to the serious illness, and most oftentimes they are covered by that benefit. Now, there is a copay for medications, but a lot of hospices waive that copay. So typically all of that is covered at 100%. We mentioned that care is provided primarily in the home. And I also just wanted to make sure you understand that volunteers account for 5% of hospice care, and that is required that we utilize volunteers for at least 5% of hospice care services. As we mentioned before, you do not lose your relationship with your primary physician. If you want to maintain that relationship, you absolutely have the right to do so, whether it's a physician or a nurse practitioner or a physician assistant. Hospice nurses and doctors are on call 24 hours a day, 7 days a week. They are not in your home 24 hours a day, 7 days a week, but they are available to visit even in the evening, at night, or on the weekends, depending on what the care needs are and what's happening in the home. And they do come out at all hours of day and night when they need to. They try to be as proactive as possible to keep things well managed, so that you don't need them as much during those times and you don't have crises, but they're there for you when you do, and they will come and be responsive to you. There are 2 90-day benefit periods. So at the end of 90 days, there is an evaluation. Does this person still meet the criteria, the eligibility to be in hospice? And if so, the medical director will sign that certification, and the individual will go into another 90-day benefit period. Then it goes down to 60-day benefit periods, because really, if you think about it, Medicare is trying to ensure appropriate use of this benefit. But it doesn't mean that at 6 months a person is cut off from this benefit. These benefit periods are unlimited. So as long as that hospice physician feels that person is appropriate, they will continue to care for them in hospice. There are occasions when people improve in hospice care and they no longer can say this person has less than 6 months to live. And so they are discharged from hospice at that point and connected with other services as appropriate. If there's palliative care available, that's a lovely service to connect that individual to, so they can continue to follow them further upstream from the hospice care. Now, ironically, while some people are afraid to access hospice care because they don't want to believe that they might be dying, when they are discharged alive, a lot of people don't like that either because they love these benefits. So again, anything you can do to help people access this benefit in a timely manner so they can get the most out of it, we encourage that. As long as they're appropriate for hospice care, we want them to get that care for as long as they can. There are also 4 levels of hospice care. So there's that routine home care level, which is what the bulk of services are provided in. There's also an opportunity for continuous home care in the home for periods of crisis. So if a symptom cannot get managed, and that means the nurse needs to be in there for 8 hours of a day, or an aide and a nurse need to be in there for 8 hours or more in a 24-hour period, then you need continuous home care. And they can do that until that crisis is resolved. This is a good level of care for individuals with dementia who may also have, say, they might have COPD or heart failure. You would expect that you might have times where there's an exacerbation of the symptom, but moving that individual who has dementia can be very detrimental to their well-being. And so being able to provide continuous care in the home for a crisis, if one should arise, is a great opportunity. The other option is to provide that same acute level of care in general inpatient. That is another level of care for a crisis or an acute need. And you can, then in that case, the patient actually moves to a new care setting. It depends on where the hospice has a contract for that level of care. Many hospices contract with a local hospital for that care. They are still responsible to oversee the care plan and the care that's provided, but the care is provided in acute settings, so you have access to some more aggressive symptom management services than you may have in the home to get things under control. Or some hospices contract with a skilled nursing facility. It's really important for an individual and their loved ones when they're shopping for a hospice, because not all hospices are the same. And we do have, I believe in our materials, we're going to send you links to some ability to ask some questions and shop for the best hospice to meet your needs. But you should ask them, where do you have a contract for general inpatient level of care? Because if you want to go to the hospital, if you need that service, and you wouldn't want to go to a skilled nursing facility for that service, they will tell you who they have a contract with, and you can make a decision about your hospice based on that information. The other thing that's available that I think is just a beautiful benefit within hospice is what we call inpatient respite care. And that is up to 5 days of care that the patient is moved to, again, where you have a contract for that service. Might be a nursing home, might be the hospital, but just to give the caregiver a break. So you can do up to 5 days consecutively for that. Sometimes I have used it where I actually then did a day of routine home care and another 5 days of respite care if there was a greater need than 5 days for that caregiver to have a break from a situation. So it's a wonderful piece of the benefit.
Lori, this is John. Could you just give a quick mention while you were talking about the different levels of care, but you also mentioned how volunteers are involved. Could you just mention some of the things that volunteers do and maybe encourage some of our listeners today to consider volunteering with their local hospice?
Sure, absolutely, John. We actually have a slide on volunteers, so maybe I'll hop to that one and get back to bereavement.
Oh,
Bereavement is
you.
one way you can be a volunteer, but there's some other ways that you can do some volunteer for the hospice. You can volunteer in the office and do some administrative functions for the hospice program. You can do tuck-in calls with patients. Often a hospice will have a script for you to follow. You'll make calls to make sure on a Thursday or a Friday, does that individual have everything they need in the home to get through the weekend? Do you have enough of your medications? Or do you have enough supplies in the home? Do you have any concerns? If so, then they can alert the nurse that they might need a visit before the weekend. So that's another way. You can go into the home and provide, sit with a patient to give the caregiver a break for a spell. And they can go out and be away for a while and get a break. So it depends on the comfort level of the volunteer. A hospice will never put a volunteer into a situation that they're not comfortable in. There is training provided for volunteers so that they feel comfortable in the different types of ways they can volunteer. There's fundraising available, opportunities to help with fundraising for the hospice or engage in community activities. And then let's also go to bereavement, which sometimes someone will want to volunteer after they've experienced hospice services with their loved one. We usually recommend that someone wait a year before they decide to be a volunteer to give themselves some time after that death of their loved one. But oftentimes people have had such a good experience with the care, they want to give back to other people. And this is another great opportunity. So some volunteers participate and help in the bereavement, and they may be one-on-one or in groups to help support others that are bereaved. Hospice is required to provide bereavement services for the family, the loved ones, for up to 3 months after the death of that patient. Now we know that grief doesn't go away. We learn to live with that grief. So I don't want to by no means indicate that after 13 months, you're just fine. We understand that, but there has to be some limitation on the provision of that. Most hospices offer bereavement services to their entire community. That's another thing you can ask a hospice. What does their bereavement services look like? When you're looking at hospice services, when I think of the bereavement for the community, unfortunately, we are in a time in our country where we have many disasters, sometimes a natural disaster like a hurricane or a fire. And that is when hospices often will provide grief support for not only those that are displaced, but also for those emergency responders who are serving their community. And they'll offer grief support in those times of disaster. Unfortunately, on the other end of things, when I think of Las Vegas, when the shooting, or Orlando, hospices came and together with their communities to offer grief support during those tragedies. So that's another way that hospices go above and beyond the expectations of the conditions of participation to provide services for their community. Now, these services do vary for the individuals in the family or the caregivers. Some hospices may offer letters and on a regular basis just to help with different times in the grief cycle. Some may provide education, both written and in person, and some will provide individual and group counseling. So there is a variety, and it's always good to ask what type of bereavement services does your hospice provide. That hospice is required to do a bereavement assessment during the care. So there's bereavement support given for the individual themselves who's seriously ill and that family to make sure that everybody gets their psychological, emotional needs met as much as possible and gets the support they need to cope with what's going on. There's also a bereavement survey that NHPCO offers for our members who provide hospice services so that they can evaluate the effectiveness of their bereavement services with the caregivers of the patients they serve. This is a great opportunity for partnership between a hospice and a local faith-based organization. You know, sometimes the hospice can come in and lead some grief education. I think about the holidays are always a difficult time for individuals. You know, you can partner with one of your local hospices to say, hey, we'd like you to come in and talk about grief during the holidays for someone who's lost a loved one. That's a really good opportunity for people to support individuals in their community. We doing okay, John?
Yep, so far so good.
Okay.
Keep moving forward. You know, one interesting question, Lori, as someone had mentioned, you know, we think of hospice generally serving the elderly, but it's not exclusively that, as you mentioned. So maybe just reinforcing the wide access that hospice really works to provide communities.
Thank you, John, and thanks for that question. Yeah, hospice is for any age individual. So pediatric patients access hospice too. And the beauty of the hospice benefit for pediatric patients is that there is concurrent care. So they can continue with aggressive disease-modifying treatment simultaneous to receiving hospice care. Of course, we'd love to see that opportunity for everyone in hospice care so that we eliminate that perceived barrier to hospice care, but it's especially important in that younger population that a parent doesn't feel like they have to choose between those two things when both are needed at the same time. And then most commercial plans have a hospice benefit also. So we certainly care for individuals at all ages. Payment, we've already kind of talked about this and about what hospice covers. There is a daily rate based on the level of care that that individual's in. And out of that money, hospice has to manage it. It's capitated. They only get so much, and they have to provide all those services based on what that reimbursement is. There's some things that hospice typically doesn't cover, and that would be treatments that are intended to cure, and we've kind of already touched on that. Some prescriptions may not be related to symptom management, pain relief, or the diagnosis that the hospice is following that patient for. So there may be an occasional medication that isn't covered by the hospice benefit. That should be covered under your regular services. And that should be listed for you by the hospice so you know what's covered and what's not. And then it's really important that the hospice is really the care manager at that point in the care delivery. So it's really important to connect with the hospice anytime you feel the need for, gee, we're having trouble here. Do we go to the emergency room? You know, what should we do? Call the hospice first. Remember, there's those different levels of care. They can help you bypass the emergency room and get directly into general inpatient if that's what you need for your symptoms to be managed, or they can provide continuous care in the home. The other thing it's important to know, for hospice does follow patients in the nursing home, but Medicare does not cover the cost of room and board. Medicaid will cover the cost of room and board if that person is appropriate for that, but Medicare does not, and the hospice benefit doesn't cover that either. I put these slides in here so you would know that there is some rigor around the quality for hospice care. Remember when we talked about palliative, that really the only rigor at this point in traditional fee-for-service Medicare is the quality reporting that billable practitioner provides. So there isn't quality reporting for the whole provision of the interdisciplinary team. But with hospice, we do have Hospice Compare now. So consumers can go online and look at different hospice providers within their geography. Remember, I told you it is important to shop. And even after you look at that online, you might want to pick a couple and then ask them some questions. And again, we have some great resources, and you'll get links to that resource that you can use or encourage people to use to really make sure they get the right hospice and the right fit. They can also change hospices once every benefit period. So if they are in a hospice and not getting their needs met, you might want to encourage someone to think about looking at a different hospice and finding out if they can meet their needs better. Again, hospice is not just one thing. A lot of times we think hospice is all hospice and it's a community-based service and it's all the same and provided by the same entity, but it's not. So that's a challenge. So these are some of the things that are looked at in the Hospice Compare. And in hospice, one of the unique things is that this evaluation that's done by the family is done after that patient has died. So in other areas of healthcare, you may well have experienced this yourself, where you get a survey after you've received care for you to fill out how did that provider meet your needs. Well, in hospice care, that is evaluated by the primary caregiver after the death of the individual. So that's where hospice is a little bit unique. There is also some other measurement here in looking at making sure that a comprehensive assessment is completed, and some of these things listed here are the things that are looked at in that comprehensive assessment, and it's make sure that the hospice is doing these things. We do expect that visits as death approaches would increase, so that we make sure we meet the emotional needs of the family and the patient, as well as the physical needs. And if there's any spiritual angst, we certainly want to make sure the spiritual counselor is involved. So we do look at the number of visits in the last 7 days of life and the last 3 days of life to make sure that we are providing the support and care that the patient and the family need at the end of life. These are some of the questions that are in the CAP survey that go to the patient's family after the death. And again, we want to make sure that care was timely, that that individual was treated with respect, that the family felt they got adequate communication. You know, it's a challenge these days with families living in all different areas of the country. How do we connect? How do they want to connect? And how do we keep them participating in the care? And then making sure that we gave adequate education and support for the family in caring for the patient in the home. We mentioned that there's live discharges from hospice. There's a couple ways that can happen. An individual can choose to disenroll from a hospice at any time. You can decide, you know what, I was in hospice, but now there's an opportunity to be in this trial, clinical trial, and I want to go for that. And so I am no longer going to be in hospice. You can do that. Or the hospice may choose to, the individual can choose to transfer to another hospice. Just like I said before, you can say this hospice isn't meeting my needs. I'm going to find another one. And you can do that. And then the other way you can do this is the hospice will discharge someone if they move out of the service area, if that individual's no longer considered terminally ill, or there are rare occasions when there just is an issue of safety, and if we can't get that individual to a safer environment, there may be a discharge for cause. So when we think about partnering here, I wanted to just talk about some of the ways that you could partner with a local hospice provider or more than one hospice provider in your community. First of all, just sitting down with them to talk about the needs in your community and where you see gaps or barriers. You know, we talked about palliative care. You might want to find out which hospices in your area or your community provide palliative care services, or who provides palliative care services in your area, and where do they provide that, so you know that you can connect people to those services when you think they might need them, but they're not hospice appropriate. You can look at what can you do with a local hospice to get people connected to that service in a more timely manner when it's appropriate for them. You can partner to improve advanced care planning in your community so that people can complete advanced directives and make sure they have at least a health proxy. Even a very healthy adult, we never know what might happen. And so it's always good to have someone identified as a health proxy, and also make sure that health proxy knows what you would want if you could not speak for yourself and, you know, in time of compromised serious illness. And then you could look at an education series or providing grief support services together. So I think it's just really important that as you have these conversations, see things you can do together to support your community. Maybe you'll also want to look at what's a measure of success. Is it that we got X amount of people to complete, identify a health proxy? One of the things I did in a community I was in rural Iowa, we actually partnered with the local library and showed the movie The Bucket List. And then we had people there that could help individuals complete an advanced directive. So that was a great success. It kind of helped us normalize, you know, this is part of life. We're all going to go through it. How do we want it to go? That is the one thing we have control over. Some of the other examples here, when I was in Pella, Iowa, we did a community-based case management program. And that was because we had a lot of people calling our hospice house that needed help in the community, but they weren't hospice appropriate. And so we partnered with our local Stephen Ministries through our local churches. We had we had a nurse that we paid, but then they trained a group of volunteers, some of whom came from the church community and some were just community members. We got some funding through United Way and then through hospice donations. And we did a lot to connect people to services and resources within the community and complete advanced directives. So it was just a wonderful, simple program that had a great impact within the community because of that collaboration between the church community, community resources, and the hospice. Another example was a parish nurse program at Unity Point Hospice and Palliative Care in Moline, Illinois. The parish nurses identified people that were at high risk, that were seriously ill within their congregations, and they partnered with the palliative care and hospice services to connect people to the right resource at the right time. It might be home health care, it might be congregate meals, but it was just a great way. It might even be behavioral health. There was a lot of ways they connected, and they tracked those referrals and the resources that were used. I'm going to stop now, and I hope that we've helped illuminate you on the value of the rich hospice benefit and the opportunity for palliative care further upstream from hospice. And are there any other questions?
You know, I think, this is John, we answered most of the questions that sort of came in. I would just like to remind folks that if you're just a consumer or a family caregiver or even a patient looking for more information, NHPCO has some resources at caringinfo.org. That's www.caringinfo.org, and I believe you'll share that with the email we'll follow up with. But I just wanted to mention that. But other than that, I think thanks for reviewing all that, Lori.
Wonderful.
Well, this is Heidi. Thank you, John, and thank you, Lori. I think that was just such a rich and informative and compassionate presentation. Wow, thank you. And I think when I heard about that Stephen Ministries curriculum, I don't know, but some other folks on the phone today are probably going, oh, I'd love to see that. So I was typing to John in the text box saying, oh, maybe we should pull that together in some way we can share with others. Because what a great example, because many of our faith and community organizations have existing care ministries, and to add a layer on to how they could easily bring people into the conversation. The bucket list movie, what a great idea. How wonderful to be able to take like something that people say, I want to think out how I want my life journey to be complete and rich all the way to the end, whenever that is such a great and important conversation for folks. So, Lori, I just want to thank you so much for bringing your great wealth of experience to this conversation, and to each of. We had a robust Q&A and chat session. Thank you so much. We will be sending out all the information that John had mentioned. I want to thank John for really a fantastic managing of our Q&A this afternoon, and for Carla Cheatham, who contributed through the chat. You'll hear from her next week when she presents on the part 2. Community partnerships to improve access to palliative care, hospice, and bereavement services. Her bio is on the registration page when you register, and we will send that link out in the follow-up as well. I think unless, I don't know if either one of Lori or John or Carla have anything to add before we close for today.
I just want to say thank you so much, Heidi, for giving us the opportunity to share this information with your group here, and appreciate all that you individuals that have participated today, what you do in your communities to support individuals in your communities. So thank you so much for your service, and we just look forward to part 2.
Yeah, we do too. And I also want to thank Mary Lazar at ACL for starting us off today. And she really touched on how very important it is to have these conversations and to have an informed compassion. And I love the spirit of volunteerism, and that incredible opportunity to be of service from your own experience was really a beautiful insight and a beautiful invitation. So thank you for that. Friends, we are so grateful for your time today. Please look for that follow-up letter with both the certificate of attendance for your time today and for participation, and a recording. We will also send a drop link to the slides, as well as a registration for next week's webinar. Until then, have a lovely afternoon, and we'll talk next week. Thanks, friends. Bye-bye.